This is our discussion section on congenital TTP. I'm Dr. Marshall Mazepa.
Hi again, this is Satheesh Chonat. We welcome for any questions that you may have on congenital TTP with the diagnosis or management or anything else that we can help with.
Great. Well, maybe while people are joining and getting their questions ready, Dr. Chonat, you mentioned in your talk that kind of one of the most currently controversial, or at least we see a lot of variability in practices, and the use of prophylaxis, which is a term we use for preventive treatment, meaning treatment that's given on a regular basis, not necessarily for symptoms, but really to try to prevent complications from the disease. So give me a sense from your practice in pediatrics, when you talk to your patients about use of prophylaxis, what do you think are the biggest barriers right now to treatment? Is this a hard treatment or is it pretty easy? What sorts of things do you encounter when you talk with patients about it?
Yeah, no, it's a very important question, especially we take care of patients who are of the pediatric age group or certainly sometimes very younger. The biggest challenge is being able to, discuss this as a lifelong disease and it may need treatment, because many of the times they could actually feel really well. So the biggest question is, I'm feeling okay, why do I need to get plasma infusions? So the first thing is to help diagnose and help understand the disease from the data that we have. And secondly, we talk about the options, as we discussed, the two major options that we try are the plasma infusions and the co-aid, which is the factor 8 with ADAMTS13. I think it's important to know that there's no any trials done comparing both of them together, so we don't know one is better than the other, but certainly most of us feel the plasma infusions, just because it can be given and it tends, the ADAMTS13 tends to last slightly longer in the bloodstream. And the big question is, when do we start? Do we start them at the newborn period, as I discussed earlier, or should we wait till they have a symptom and then to start? Or because especially in the childhood, it's important to remember that many of them have viral infections, so colds and coughs are very common in the first few years of life. So it's important, are those going to be enough to trigger a full-blown TTP, or even if it's not full-blown, can it still continue to cause some micro damage? The other thing that we discuss is the plasma infusions in terms of how frequently they have to come. So especially it has to be given through intravenously. So getting IV access and a repeated IV access can be a big challenge, especially in a younger child. And also then we discuss if they have to get a central line, a line which just stays put in the body, which can be used repeatedly, so that they don't have to get an IV stick every time they come in plasma infusions. So these are several different questions. I think this is important because it's a lifelong disease. It also does put a huge burden on family and other siblings and other family members. So it's important to discuss all this while we come up with a perfect management plan for the child.
Yeah, so I take care of adult patients, and in many ways, your discussions with patients mirror ours.
Yeah.
Even though the veins are bigger in adults, it still is not easy to ask people to come every couple of weeks. And the reality is that even though plasma is very safe from, say, a virus infection standpoint, which was a concern years ago, I think we still see a lot of allergic reactions and other reactions to plasma that, it's not particularly dangerous most of the time, but it is, it's very bothersome to patients. And, so it's hard to plan the whole day. It's not like you just come in for 15 minutes and get a treatment, right? So I think we have to acknowledge those limitations of plasma. But in this disease, it seems like the complication that's really been gaining a lot of attention lately is stroke, and whether that's what we call a silent stroke, where there aren't really symptoms, but we can see it on the MRI scan, and maybe there are subtle symptoms over time, or a clear sort of classical stroke with symptoms where a patient may not be able to move one side of the body or have slurred speech. How do you talk to your patients about stroke? It's obviously a scary complication of the disease, but I think an important complication for patients and families to know about. Is that something you emphasize when you talk about prophylaxis? How do you address that problem?
Yeah, it's an important question. It's certainly in TTP, but there's other diseases who also causes silent stroke. It's challenging because we kind of try to talk to family members and the patient about what signs to look for. I think the most important thing is that do not ignore recurrent headaches, or if you're not feeling well, because signs of stroke can be quite variable in people. And we also try to ensure that they have a good medical plan. If they go to any emergency department, they could be traveling. So it's important to have a clear management plan and also be able to have good contact numbers so that the emergency medicine doctor can speak to a hematologist who's experienced in managing children or adult patients with congenital TTP right away. The other biggest issue we've had is in children is, do we do monitoring imaging or not? We don't have any great data to support should we or should we not, but I think it's important that we take several things into consideration. Is obviously the MRI, which is most ideal to look for the stroke, which is because the stroke that we see in TTP is not because of bleeding in the brain, it's because of lack of blood supply, ischemic stroke. And when you do it, when someone comes with symptoms, you may not actually pick that up on a CT scan, but in children to get MRI, many of them need a sedation. We have to put them to sleep because it does take about 30 minutes or longer sometimes, maybe shorter if we do some kind of stroke protocol. The question is, do we do them routinely? Do we put them additional anesthesia? That also additional risk. So these questions are something that we actually have a discussion with. You certainly take care of adult patients with congenital TTP. Do you have a similar discussion, or is that something a little bit more easier?
Yeah, we don't do any routine imaging, just like you. But I think certainly there's talk about moving that direction in the field. But right, I think discussions about what are the clear benefits of prophylaxis. We mentioned complications and how it's disruptive to your life, but the ability to prevent a stroke or other long-term organ damage, I think, is a really important reason to think about prophylaxis. I think traditionally, both for some congenital patients are first diagnosed in adulthood, and for kids who are diagnosed with this disease, there's always been a long debate about, do we start prophylaxis or preventive treatment with the first episode or the first symptom, or do we start before the symptoms starting? I feel like the field has really been moving more towards starting before the first symptoms. Is that your take on things? How do you feel like those discussions often go? I think it's harder because it's really hard to really see the benefits.
Right.
And you haven't had a complication. So it's sort of, it can be challenging. We want to protect people, but we also don't want to be disruptive to their life. Is that your take on things?
Absolutely. I think over the years, we've certainly recognized, and also from several other studies from other parts of the world, is that that patients who may actually feel okay, they may not necessarily actually have a completely normal organ function. So it's important to kind of monitor organ function. But I think it's important if it's a baby who gets diagnosed, do we start right away prophylaxis? And so if so, do we continue? How long do we continue for? Several challenges to it in terms of cost and risk of allergic reactions and so on. I don't think I have a great answer in terms of the preference, because I think it's important that we have to discuss that with the family members, understand the risks of both pros and cons on chronic treatment. The next question actually is, it's perfectly as a segue to it. So what is a safe ADAMTS13 level we maintain? By doing plasma infusions, as I mentioned, it does increase your ADAMTS13 level, but does bring them back into the baseline. So the question is, do we maintain a level of 20 or 30%, or should we keep them normal? It's definitely an ongoing discussion within our community. So all of us have own preferences based on certain sometimes experiences, but also some of the studies are shown. But I think it's important to remember that hopefully future studies can help answer that question. Do you have a take on it in terms of what's a safe ADAMTS13 level should be something that is trough, meaning we need to maintain a level all the time, or it's more important about the peak levels after giving plasma? Yeah. How high does it have to go?
Yeah, it's a question that I think we just don't really know the answer to. For most of my patients who receive plasma, we still really can't detect ADAMTS13 after the plasma infusion most of the time. And that's because it's not there, it's because the tests aren't really sensitive enough to pick it up. It's a very difficult test to do, so only a few laboratories around the country are really good at it. And so generally, my assumption is the levels still stay below about 10% of normal. We always talk about ADAM TS13 as a percent of normal, where 70% is considered what's typical for most people in the population. And certainly people can have more than 100%. So right now with the tools we have, I don't necessarily target a specific level. I think what we've seen in immune TTP, if it's any guide, is that most people when they relapse are below 10%. I've seen patients relapse with levels maybe as high as 20%. But I think the reality is that we don't really know what, once we have, say, recombinant ADAM TS13, where we will be able to give doses high enough to measure the amount of ADAM TS13 in the blood, I think we really don't know what a true safe level is. I think most of us would prefer to make sure that level of ADAM TS13 stays above, say, 10, 15%. And you're right, you mentioned those words peak and trough. When we give the medicine, you can imagine the level goes up and then will sort of fall off as the medicine wears off over time, and then we give the next dose. So we talked about the peak, the highest level of the medicine in the blood, and the trough, the lowest amount of the medicine before the next dose. So typically in related diseases like hemophilia, where there's a missing blood clotting enzyme, we've tried to use our treatments to maintain a trough in a safe range. So I think I would extrapolate from that experience and say we probably want to try to find what is the level above which we want to keep patients. It's probably at least 10%, but I think we don't really know long term. So I think that really gets to a good point, is assuming the medicine does get approved, I don't think that's the end of the story, right? So like so much we see in medicine, right? It's not that the problem is solved and we go on from there. I think there's still a big need to understand what's the best way to give the medicine. It's certainly going to be a more convenient, and I think hopefully from a reaction, infusion reaction standpoint, safer than plasma. But I think those questions right now are assumptions that I think we're hopeful for, but I think not the end of the story.
Absolutely. Right.
And I think we'll be working together as a group to try to help everyone understand what is the best ADAM TS13 level to target. So another question from the audience about what triggers a TTP, congenital TTP episode. What's been your experience, Dr. Chonat?
Yeah, it's a good point. So, one of the things that we commonly see in our infections is certainly our inflammation of that kind. I think that newborns, where we tend to see a presentation, as we discussed earlier, it's probably some of them are actually sick, or it's just the whole stress of the delivery in itself could actually slightly increase the risk of presentation. And we don't know as to what other triggers. Is it the ADAM TS13 going down? Or is that just that there's some other factors that we still don't know that could be actually playing a part? In addition to having low ADAM TS13 is why they come in. We talked about pregnancy, as we know the few reasons. One, there may be a slightly increased risk of inflammation, so the levels of 1 milligram factor slightly higher, so hence it may kind of consume more ADAM TS13, in addition to having a low ADAM TS13. And certainly, people have talked about excessive alcohol intake in some patients who presented with congenital TTP. So there's several listed in the literature in terms of what triggers it. But at least from the type of patients that are taken care of, it's usually infections or some kind of inflammation.
Yeah, I completely agree with you. It seems to be the commonly described phenomenon is acute illness, and that childhood illnesses, which obviously I think when kids enter school or enter say like a daycare setting is very common, and can be a really tough time for families. In adults, sometimes the very first manifestation of the disease comes at pregnancy. So we always think if we see a patient who's newly diagnosed with TTP during pregnancy, that we really have to think hard, is this congenital or immune? And then I've seen it several times in surgery as well. Yes. So stressful situations, when the body reacts to stress, and that can be from infection, surgery, pregnancy, von Willebrand factor goes up, and that's that big sticky protein that von Willebrand factor, or that ADAMTS13 is trying to chop up. I love the scissors cartoon in your slides, because that's how I think about it too, is it's trying to chop up that von Willebrand factor so it's not quite as sticky. So really those stressful periods are the times to really be aware of for a TTP relapse. It is true that, the body probably tries to find a way. There are other proteins we know that help regulate the size of the von Willebrand factor, and during those stressful times, that balance just gets tipped and causes a relapse. Let's move on. There's another question about how often to give plasma.
Yeah.
So
we talked about it. I can give you I talked a little bit about what I typically do and what other studies have shown. What are your thoughts and patients that you?
Yeah, certainly. I think it's always good to start with a textbook. I think we try to give plasma every 2 weeks, but we realize that may just not be feasible for most people. Because it's really kind of a half day we're able to do it in the infusion center. Are your kids admitted to the hospital, or are they able to get plasma?
We're able to give it. Typically, most bigger pediatric hospitals have infusion centers, so hence we're able to do it on an outpatient basis. But it still does require a few hours of coming in, getting the blood tested, waiting for the infusion, watching for reactions after the infusion. So it does take a few hours.
Yeah. So sometimes I've backed off to every 3 weeks. But I think it's really on a patient-to-patient basis, right? I mean, I think I'd rather have a patient who's frustrated with every 2 weeks infusions go to every 3 weeks than to stop altogether, right? So sometimes you have to work with patients and families on what makes the most sense. How about, one thing we haven't talked much about is coate and making the change from plasma to coate. I think it's harder in adults because we know that it will increase the level of factor VIII, and so that's
it's actually a question.
Can cause stroke in itself, and so that's a little more challenging. But how about kids? Have you had kids and families decide to make that decision to change from plasma?
Yeah, personally, I have not done the transition, but I know some of my colleagues who have had to do that, where they have had to change from plasma to coate. I think it's important to note that you want to avoid doing that change, especially during an active infection or inflammation, because the factor VIII levels are slightly higher during those times. So it should be best time to try some of it is if maybe at a quiescent phase, so the patients are unlikely to have symptoms or infections or surgeries. So that may be the best time to try. But again, it comes back to the question in terms of that ADAMTS13 level. Usually it's undetectable also very quickly, even after it's done. But certainly there are advantages of doing it. But it maybe have to be given more frequently in some individuals. One of the things, both the plasma coate we talk about is symptoms. If many people try to come every 2 weeks, especially if they have symptoms, and once they actually feel better with symptoms, they may actually just back off a little bit. So sometimes we actually, though they're prophylaxis, we do kind of do in demand or on demand during prophylaxis period to kind of do a little bit more frequently, intermittently. And that certainly has worked. Like you exactly said, I think we have to work with everyone, patients, family members, and so on to see what's best for them.
Yeah, home therapy, right? I mean, revolutionized hemophilia. In many ways, we were mirroring hemophilia, which was treated with plasma and other plasma products through the 1960s. And then home therapy with factor concentrates, so sort of freeze-dried plasma proteins came into the picture. And I think we may start to see that with both coate, and certainly I've had patients change to coate for that very reason, that they can give therapy at home, which can be huge in terms of quality of life and ease of care for patients. So I think an important part of this. I think it's a harder discussion in adults where it can be a little bit riskier. So we get a little nervous about that. But again, I think tailored to the individual patient. So maybe let's move to the next question. Can women with congenital TTP have kids?
Yeah, so, again, when I see children or young adolescent women, I do talk about it. I think it's important that it's a informed decision that they take in terms of pregnancy, and it's preferably it's planned so that the obstetrician and the hematologists and the patient actually has a very important discussion together in terms of how they're going to manage. And oftentimes, if it's myself as a pediatric hematologist, I certainly will involve an adult hematologist or transition the care in advance so that they can actually get that established, and ensure that they actually discuss with the obstetrician who are comfortable managing someone. So in terms of the actual question, can women have congenital TTP have kids? The answer is yes, it's possible, but it's important to actually ensure that we do adequate prophylaxis, because pregnancy can be a trigger. So hence it's important to monitor ADAMTS13 levels, platelet levels, and also typically they're seen by a high-risk obstetrician who can actually follow also the baby along with the mother. What are your experiences been?
Yeah, I would completely agree with you, right? I mean, having a high-risk obstetrician or a maternal fetal medicine specialist involved, I think, is paramount, which usually means being managed at least at a higher level medical center where people are familiar with the disease. But you're right. I mean, I think as long as we're aggressive with prophylaxis or careful in our planning, that we can get women through pregnancy. I think it all comes down to your team, right? Talking ahead of time, finding the right doctors who can work with you, having a plan for management of the pregnancy. That's all really important. And we realize that can be really challenging, right? I think all of us would prefer to not have to have loads of medical visits, but the reality is the goal here is to keep you safe. So yes, we can get you through a pregnancy, but we really need you in the hands of experts. So it looks like there are a couple of questions about COVID and vaccines, which to me are related questions. These have to do with infection and the immune system. So have some of your congenital patients ask you about the safety of the COVID vaccines and other vaccines, and what about COVID infection?
Yeah, it's a good point. Now, I might have mentioned, talk is that vaccines can potentially be a trigger, and we know that with TTP, but I think it's important that to understand that the risk of infection is still far outweighs. So hence it's important. The benefit of vaccine is much higher than any kind of downsides with the infections, because it's important to know, especially with COVID, we know that there is increased risk of blood clots with COVID, and patients with TTP also has increased risk of blood clots. So hence, patients who get COVID infection can do poorly. We've had even in young children presenting both immune-mediated TTP, presenting with the COVID infection and needed a full plasma exchange and so on to help manage them. They've done very well, but it's important to recognize that the risk of COVID could definitely exacerbate their underlying TTP status. We had similar concerns. Again, children in general have done reasonably well with COVID infection, unlike adults.
Yeah, I think one of the biggest challenges with COVID is that this virus tends to create a lot of inflammation. So the immune system in some people tends to overreact. And so certainly can trigger a TTP relapse. And on the flip side, what about vaccines? Is that a safe thing? We're basically stimulating the immune system. So in general, I have really encouraged my patients to get vaccinated, because in general, the risk of the vaccines is lower than the risk of the infection. And that's, in really all of medicine, that's what we're doing, is trying to understand what seems to be the bigger risk in weighing these two things. So for a lot of my patients who have a lot of concerns about the COVID vaccines, the way we make it safer is we monitor. So, what's the platelet count before the vaccine? Let's come back a week after your vaccine for another platelet count. If it seems like the immune system is overreacting to the vaccine, well, we are more aggressive with plasma to try to prevent a relapse.
I agree. That's our practice as well, to actually ensure they get a platelet count before the vaccine, and also to come back in a week or two to get a repeat platelet count. And actually, most of them have done really well. I've not had any concern from COVID vaccine-related TTP so far.
Yeah. Speaking of platelet counts, the next question is about what's your personal platelet count threshold for a plasma transfusion, which I think there isn't a universal agreement here, but in monitoring patients with this disease, obviously our main tool is the platelet count, and maybe talk a little bit about how you might use that to make some decisions with families about when to treat.
Yes, it's tough because we use platelet count. We also use ADAM-TS30. I think it's important to know what is patient's baseline platelet count, and I think we try to do that over a matter of a few months, just to know where the platelet count lies. Is it definitely on the normal side, or does it go down? How low does it go? And again, most of these platelet count numbers in terms of risk and the numbers are derived from the other studies, because I don't know if you know exactly below this platelet count, there's a higher risk of suggesting that there could be a microclot that may be forming because the platelets are getting consumed with that sticky substance called BWF. My personal preference is actually to keep platelet count as closer to normal as possible, but certainly also monitor the ADAM-TS13 level. I feel that seems to correlate somewhat with infection. We do not have great data to see which one correlates better with symptoms either. So I think it's important to know what your baseline platelet count level is, and then discuss with the hematologist and internal medicine doctor. How do you manage such?
I think it's a tricky question because, like you mentioned, what does the platelet count dropping mean? It means that platelets are clumping together and forming clots, and the reality is that only a small drop in platelet count, if the clot's in the wrong place, can really cause a lot of damage and symptoms. So there is variability from day to day in the platelet count. So you can see week to week, a range from say 30 to 50,000, right? I mean, it's not the same platelet count every single time. But monitoring up front when you're starting either on prophylaxis or if you're just monitoring, it's important to sort of see what's the person's normal range. And I agree with you. I'm pretty aggressive because what I worry about is those silent strokes. They're not causing symptoms, other organ damage. So if there's a clear downward trend in the platelet count, I'm quick to intervene. I guess I don't really have I can't tell you a specific platelet count. But to me, when I see a platelet count has fallen outside of what I think of that patient's normal ranges, I'm thinking that's a sign that there's danger on the horizon. And I guess in my experiences, it's easier to treat a patient whose platelet count has just taken a small drop than a patient whose platelets are now single digits, because now you really got to break up a lot of platelet clots. It's going to be more time where there's organ damage. So I guess I'm a quick to intervene personality, but I think everyone has a different threshold, and I think you have to try to find a doctor whose practice style matches your own.
This is also important to know that how high does your platelet count go after those plasma infusion? Do they go back to normal, or how high does it go? And I think that also helps you understand. Another question on platelet count, how much range for they are actually. It is exactly the same range, but it's important to know there could be small differences in the ranges between the blood machines or the analyzers in different labs. So it's important to use that range, but otherwise they should physiologically, by the time they are, after the newborn period, the platelet counts should be normal as adult ranges.
Yeah, and I really sort of think about a platelet count as a personal platelet count range. When you test for the general population, the range is from about 150 to about 400 or so.
Good point.
But there are plenty of people who have a platelet count of 110 who don't have congenital cTTP, and they're perfectly fine. Other people with platelet counts in the 300s, and they're just as well too. So I really want to emphasize to people that they kind of know what their normal range is. And when you start dropping, that can be a sign of potential danger. So yeah, again, I don't think there are any universals in terms of when to intervene, those sorts of things. But again, I think in the interest of trying to protect people from kind of the unpredictable nature of the organ damage, particularly stroke, I guess our suggestion is early intervening, because we just don't know what's right around the corner in the next few hours or days.
I think we're almost at the half of the hour.
Well, great. Well, thanks for
Thank you
such a
very
great
much.
discussion.
Yes.
Certainly write to us if you have more questions. We're happy to hear from you. We'd emphasize to you that the recombinant Atom TS13 trial is ongoing. You can find information if you're interested in participating and reaching out to the study teams at clinicaltrials.gov if you want to learn more. Thanks everyone for your time and attention, and have a great rest of the day and enjoy the rest of the meeting.
Thank you for your participation.